So I'm Dr. Suchanda Sar. I'm a senior consultant, glaucoma and cataract services, Disha Eye Hospital. My esteemed co-instructors hardly need any introduction. They are all well known at state and national levels and are all active internationally also. And as per instructions by Sihota ma'am, I will really cut down on the introduction time so that we have more time to actively interact at the end of this session. But just one word, after me, my speaker, Dr. Manish Singh, the smiling, energetic, young glaucoma practitioner of Kolkata, will be the next speaker, and then followed by Dr. Dipanjan, who is senior consultant with Disha Eye Hospital, very proactive and dynamic. Dr. Chandrima Paul, Secretary GSI, dynamic, one of the doyens of glaucoma in Kolkata and Eastern India, needs no introduction. And last but not the least, definitely, is Ramanjit ma'am. And she has categorically told me that she does not want time to be spent behind any introduction. So we move on. And one thing that I need to definitely say about her, that she is one of the most dedicated, exemplary teacher that I have seen so far. And it is really a privilege to have her in my IC today. And for that, I need to thank Dr. Chandrima for encouraging me to rope in Dr. Ramanjit Sihota. So my talk starts now, Nikhil, and I will speak on epidemiology of primary angle closure disease. Primary angle closure disease is not a single disease. It is a spectrum and varies from narrow angle to advanced glaucoma. The current classification by AAO in 2021 encompasses 6 clinical conditions under PACD: PACS or primary angle closure suspect, primary angle closure glaucoma. These we will be discussing later on. Acute angle closure crisis, where the angles are occluded, leading to raised IOP. Plateau iris configuration, these are patients who have narrow angles due to anterior ciliary body, and they have central deep AC. And amongst these patients who still continue to have persistent iridotrabecular contact, in spite of having patent peripheral iridotomies, are called plateau iris syndrome. A lot of research, a lot of discussion. PACD is one of the most discussed diseases in glaucoma even now because it leads to a lot of blindness. Angle closure has been seen to be the fundamental pathological process, but with better understanding of the disease, with better diagnostic tools, we have seen that apart from pupillary block and plateau iris, multiple mechanisms are contributing for closure of angles such as choroidal thickness, uveal thickness, and now lately the GIVA studies or the genome-wide association studies have also identified new PACG loci and genes, and maybe these will help us in better management of some PACG patients in future. It has also been said that psychological status and balancing the sympathetic parasympathetic activities may also lead to better prognosis of PACG. Yanov et al. In 2014 described PACG as those with elevated intraocular pressure due to mechanical obstruction of the trabecular meshwork, which could be either appositional or synechial. But till date, the search for a very standardized definition of PACD is still on. There has been a plethora of classification and terminologies, and it started as early as in 1966 when G et al. Came forward with a classification based on clinical presentation. It was later updated by Salmon et al. And they classified the clinical course of acute PACG into preclinical attacks, acute, subacute, intermittent, chronic attacks, progressive attacks, and absolute according to signs and symptoms. In 1998, a couple of glaucoma epidemiologists got together at the Congress in Netherlands, ISGEO Congress, and they decided to come forward with a classification. And finally, in 2002, they published this classification where they called those patients with 180 degrees iridotrabecular contact or more than 180 degree, normal intraocular pressure, no optic nerve involvement as PACS or primary angle closure suspect. Primary angle closure were those with iridotrabecular contact and peripheral anterior synechia with or without elevated IOP, but no glaucomatous optic neuropathy. And those who had glaucomatous optic neuropathy were coined as PACG or primary angle closure glaucoma. Till date, this is considered to be one of the standard classification and is most commonly used in population-based epidemiological studies. But like other classifications, this too has its drawbacks, because under the classification of PAC, there is a wide spectrum of clinical cases which could be just a single peripheral anterior synechia, a part closure of the angle by peripheral anterior synechia, or a total closure of angle. And they could have normal IOPs, they could have raised IOPs. The only thing that they had in common was that they did not have a perimetric optic nerve glaucomatous damage. But this gamut of entire cases who were classified only under PAC did not have the same, the management protocols were different, but they were just getting classified under one head. So to overcome this, we are still on the lookout for a better classification, a more concise classification where the pathogenicity will be included and subsequent management protocols would also be a pointer from that classification. So the pathogenic classification was first attempted by Rich et al. In 1996, where they tried to classify PACD according to the anatomical levels of obstruction to aqueous flow, which could be at the level of the iris, the level of ciliary body, the level of the lens, and vectors posterior to the lens. But however, it was seen that in some ACG patients, multiple levels were responsible simultaneously. So they could not be classified at one single level. One of the nearest classifications that have come towards a standardized classification is one that has been proposed by Dr. Ramanjit Sihota in 2011. She has classified the clinical criteria under gonioscopy, IOP, optic nerve head, and also with a management protocol depending on the staging. This proposed classification has amalgamated all the clinically described subtypes of PACD into a staging based on the extent of damage to the outflow and the optic nerve head, providing a basis for standardized therapy and possibly a quantifiable long-term management. Glaucoma prevalence is rising, and so is the morbidity. And it is expected that in 2040, we will have a walloping amount of 32 million cases only of PACG. So PACD will be far more than that. Now, why? And it has been seen that PACG varies across geographic and ethnic groups. And we in Asia happen to be one of those countries where there is a huge load of PACG cases. In 2014, Tham et al. Said that Asia alone accounts for 77% of the worldwide PACG cases. In 2010, Ronnie George et al. From Shankar Nethralaya, they did a study. They stratified data from the 5 glaucoma studies, that was Vellore, Chennai, Andhra Pradesh, West Bengal, and Arvindai studies, and along with the population census data, in 2010, they estimated that we had 2.54 million PACG and about 10 times more than that PACD cases in India. And what is the major challenge is that most of these diseases are undetected and let alone being treated. PSEG also carries a much higher risk of increased risk of severe bilateral visual impairment. But what is the brightest light at the end of this dark tunnel? That PSED is a potentially preventable disease. And if the angle closure is halted in the early stages by treatments like laser peripheral iridotomy and or iridoplasty or lens extraction, medical therapy, then we can actually stop many from getting blind. And that is why we need to, what we are doing now, we need to keep on promoting, we need to keep on shouting at every possible forum, at every possible glaucoma workshop, the importance of gonioscopy, and to say that it is mandatory for the glaucoma examination to be completed. We need to break down these mental blocks against gonioscopy. We need to do hands-on workshop where we can actually show that it is not as difficult as it is portrayed to be. And I think that will go, and we need to do it at the PG level. And I think that will really help us to gift many sight years to many patients. The purpose of this IC is to talk about these, to talk about the latest updates that have come up, the latest updates that have come up for medical treatment, the latest updates that have come out about diagnostic tools, the latest update regarding iridotomy, iridoplasty, and the latest concepts that have come up about the surgical protocols for PSED. We will be discussing in this IC, and we will be looking forward to an interactive session after that. And before I end, what I need to say, what I want to also emphasize, that long-term follow-up of these PSED patients are very much necessary, because these patients, some of these patients continue to progress even in spite of our best efforts. So thank you. As we move on to my next esteemed speakers until the end of the IC. Thank you so much.